All right, good evening, everyone. Thanks for joining us. And we'll try to talk about patella instability. Basically, your kneecap popping out of socket is what we're going to focus on here. So this simple anatomy here, you can see, the patella is supposed to be seated into what's called the femoral groove here. And that's kind of what locks it in place. And when it's out of there, then it's dislocated or shifted or subluxed away. So there's a whole bunch of reasons why this can hurt in this area or reasons why it may dislocate. One reason could be that the shape of the patella isn't, like a V here or normal, where you see picture A, where the medial and lateral, the two sides are equal. If it's narrow or shallow on one side, that could make it pop out and not stay locked in. A lot of stress can lead to micro damage of this. That's why people may have trouble or pain when they're going up and down stairs or sitting in a movie theater or an airplane for a while. And part of it is all these muscles on the left side here are your quad. The quad is one of the biggest muscles of the body. And all that attaches to that little kneecap, and it can pull it in certain directions based on where you may have one weakness or another in the four muscles that come together to make up the quad muscle. So you can see here, this kind of all these arrows where, the quad muscle's pulling it up. There's tissues on either side of the kneecap that can pull it, in or out. And there's the patella tendon on the bottom. So tightness in any one of these areas or an imbalance can shift it out of position. It could be your bony alignment, just the way that you were made. Some people are bow-legged or knock-kneed. You can see in this picture how this person is knock-kneed and their leg goes away from their body. So we just saw a 14-year-old girl an hour ago in the clinic who has this problem, who's battling her kneecap popping out. And part of the reason is that her alignment is shifting this kneecap out from the pull of all that muscle. One other reason could be that your hip is too rotated. So you can see this with people that kind of walk pigeon-toed with their toes pointing in. Their hips are internally rotated, and that mismatch between the hip and the knee can cause the patella to dislocate. Now, it's not going to happen typically with just walking, but it can happen with trying to swing a baseball bat or, making a sudden pivot. Or, I've had people go bend down and pick something up in their closet and it happens. That's typically not the case. It's more of a traumatic thing, but certainly can happen. And these are some of the bony reasons why, and not just the soft tissue. What we talked about earlier a little bit was the quad pull. And some of this is related to this Q angle. So the quad muscle, the muscles pull up this way towards the hip. But sometimes your tubercle on the tibia here is not lined up straight and it's off to the side, to the outside. So again, that makes the patella want to go to the outside. So a high Q angle can cause that. So these are kind of going over some of the things we talked about. The names here are femoral anteversion. That means your hip is too rotated. Tibial torsion, that means your leg or your tibia is too far rotated to the outside. And the TT-TG distance has to do with that tibial tubercle. And these are things that we measure, and I'll show you this later in x-rays to give us these exact numbers. How your foot hits the ground, when you walk or when you run also plays a role here. So, people that have kind of an increased knee adduction, meaning their foot is, over-pronated or under-pronated, can affect this. So sometimes orthotics are used to help correct the foot angle, thereby putting less stress at the knee. So people typically come in after a traumatic event, their knee is swollen, painful, and we try to get an assessment of what's going on. We get some x-rays, listen to the story, because a lot of times that tells us, what happened. And then from there, decide, is this something that we can just do some therapy on, or do we need more advanced imaging? So some of the tests that you'll see in the office, and these are specific to patella dislocating. There's other normal knee exam things, but we're focusing here just on testing the instability. And what we do with that is we just take it and pull it to the outside. And sometimes the patient will jump up because it's very painful for that. If it just happened, if it's something that's been going on for months, it's not as painful, but it gives us an idea of how loose that kneecap is. We'll have somebody kind of sit on the bed and extend their knee, go from flexion to extension here. And we watch how this kneecap moves. It should move up and down, but if there's this kind of J curve to it, then that gives us an idea that there may be too much movement here. Because as you flex, this kneecap has to come into the groove. I'll show you another picture of that later. And if you're someone who's dislocating a lot, it's going to tend to sit outside in extension, kind of shift it out. And as you flex in, it comes home, and you'll hear a click or feel a click in there. And that's when people can get grinding from arthritis as they flex and extend their knee. So again, just going over some of the things, we check to see how much tilt there is in the kneecap, and we grade it based on this middle picture. You can kind of see the 1, 2, 3, 4. It shouldn't be more than 2. It shouldn't be more than 50%. If we can take it all the way to 4, that's a big problem. So sometimes it's related to muscle tightness. And so these are just showing some assessments of that and ways to stretch your hamstrings and your quad muscles. So we want to check again. Is it your foot? Do we need Achilles stretches? Do we need hip stretches here? So these are just some different things you may do in the office to help us assess the problem. And it's just showing too much rotation on the hip. So this person is on their belly, and you can see how far out their leg is pointing. Or you'll see kind of people who tend to sit instead of cross-legged, like Indian style. They'll sit with their legs pointing back. You see kids doing that all the time, and I try to remind my kids not to sit like that, just to not affect their femoral development. But sometimes that's just more comfortable for that kid. We get x-rays. This shows you how this is tilted and kind of subluxed or shifted out a little bit out of the groove. We also measure your patella height. Some people have a kneecap that sits too high. And if it sits too high, then that makes it more prone to popping out of socket. And all of these things give us more information so that we know how to correct it. So one other problem is that V, that groove that I was telling you about. Normal has a nice V and the patella can sit there. There's patients where their groove did not develop enough, and that's called hypoplastic. And so there's nowhere to lock that kneecap into so that it can't shift in and out. And then there's dysplastic, where the groove didn't form at all. So you can see how this one is way to the side. Also on this MRI, we're looking at this ligament here. That's the medial patellofemoral ligament. I'm trying to point to it with my arrow. And that is what helps hold the kneecap in place. But it's a very thin ligament. And when it gets hurt, it rarely comes back to its normal tension. It always stays a little bit loose. And some people can get by with that depending on their activity level, but others cannot, and it keeps popping out. So we can get a CT scan to assess your hips. We get MRIs to assess for cartilage lesions. This is showing, the CT measuring the rotation of your hips and ankles and trying to isolate where the problem is. So I want to show you one more thing here. So the gray over here on this picture on the right where my arrow is, that thick region there, that's the cartilage. So what we see sometimes is when you dislocate it, you knock off a piece of this cartilage, and that can cause long-term problems. And I'll show you some pictures of surgeries we did where we see that. So non-operatively, we do bracing. It's called the J brace. Again, it helps. There's a band right here on this brace that helps keep it in, prevent it from coming out. And there's different orthotics we can use, focusing on rehabbing the quads and getting strong so that the pull of this muscle is appropriate and you're balanced on each side of the knee. You know, strengthening the hips. You got to strengthen the whole chain from top to bottom. We do taping, especially for athletes, you know, that have had this problem. They want to continue playing their season, try to avoid surgery. So we can tape it and try to pull the patella to the inside, but, you know, through the skin and different forces to help, you know, lessen the impact of that. So non-surgical treatment should be pursued until the clinician and patient are certain that a plateau has been reached. Can the patient return to their activity level? So the young girl today, she wants to be able to play softball in her senior season, which begins in March. But if we did surgery today, it's a 6-month recovery. And so it's too close of a time frame for her. And so we're trying everything here to get her to that level. And then if needed, we do surgery after her season. So the goal is to correct the primary lesion. What is the source of the patella dislocated? There's a lot of surgeons that will just treat the ligament. But if you just treat the ligament and it's a bone problem, the same thing will recur. So you want to go to the correct sports medicine specialist that's trained in femoral alignment, tibial alignment, osteotomies, in order to be able to treat the whole problem. And so, you know, that's very important in deciding who and where you go to help treat the problem. Because fixing one thing may not solve the problem. Okay. So when we get into surgery, you know, this was from 2 days ago on a 17-year-old on the left picture here. You can see how beat up his cartilage was from its popping out. He popped out 4 different times. He's a basketball player. And so we went in there and we kind of shaved this cartilage a little bit, but this now sets him up for arthritis. And, you know, 15 years from now, it may end up like this picture on the right, where it's completely down to bone and there's no cartilage left. And that can obviously cause a lot of pain and dysfunction. This person, this is the femur here. So when I'm talking about the groove, this young man, he's 14, you can see the piece of cartilage here hanging out in the knee. He completely knocked off the cartilage when his kneecap popped out, and it sheared off all this cartilage from his groove, from his trochlea. So this is a very bad problem because of the size of this lesion. You know, small areas you can maybe get away with. Just think of driving on a pothole. You can drive over a small pothole, but big potholes cause your car trouble. You can see in this bottom picture how much his kneecap is shifting away out of that femur, almost off the picture. So he's gonna need, we're getting ready to soon do a cartilage transplant here in this area because he's now 6 months and still having a lot of discomfort and pain. One thing they used to do, and this is uncommon now, is what's called the lateral release. So the theory was, well, it's so tight on the outside, let's just cut that band and the patella will recenter. But again, you know, they were thinking that would help, but they were treating the wrong problem. The problem wasn't necessarily on this side, it's the problem was on this side, on the inside of the knee. And so the other issue with this is when you cut this, sometimes it starts shifting to the inside, whereas 90% of the time, the problem is people shift out. So you've now created a new problem and people were shifting in. And we've had to go and kind of fix some of these surgeries that were done many years ago when we didn't really understand the problem. So one of the bony corrections is called the tibiotubercle osteotomy. So when this angle is too high, we have to shift it over to line it up better. And so we cut some of the bone and we move it over and then we screw it down. This is again from the surgery we did about 7 months ago. And he's going back to sports now. So you can see here, these 3 screws, there's a faint little line there that's the area that we shifted over, okay? In the kneecap here, in the femur here, you see this hole. So that's where we put the new ligament. There's a screw there, a plastic screw, and two in the kneecap that are holding the new ligament. So he had two procedures, one to correct the ligament, the soft tissue, and one to correct the bone. Sometimes, again, like I said, the problem is at the hip. So we make a cut in the bone here, and we kind of rotate one part of the bone to correct that internal rotation. So the person's foot is pointing too much inside, and we shift it and we make it point straight to take pressure off the problem that's way down at the bottom at the knee. This is called a Blake plate, but this is called a derotational osteotomy. And this is kind of, again, showing you a picture of that ligament and how far this kneecap can shift over. And this is what I described before. We take a cadaver graft, a cadaver tissue, and we make a new ligament to replace this old one. Again, this is a newer technique that's been out over the last 5 years, is we figured out how we can deepen this groove without hurting the cartilage under it. And that's called the trochleoplasty. So there's certain people, like I said before, that their bump is too high, so we have to shave that down and allow this kneecap to sit home or in a groove. And so what we do is we lift up the cartilage carefully right here. So that's all the cartilage. And then we take the bone and we cut a wedge out of the bone, and that helps deepen it. And then we seat the cartilage back down and we hold it there with some heavy, strong suture. The end result of all these things, like I showed you, is when people get arthritis, we have to do what's called a partial knee replacement, where we just replace the part underneath the kneecap. Now, you know, we don't want to do this in 20 and 30-year-olds. And thankfully, we have all these other procedures to help restore cartilage and work on correcting the alignment better. But in our 50 or 60-year-olds, or even rarely in our 40-year-olds, that just have such bad arthritis that it can't be replaced, or the cartilage can't be replaced, we do a partial knee replacement, and we use this robotic assisted surgery. And these can be outpatient procedures, and that, you know, can last 10 to 15 years. And ultimately, people will need a full knee replacement, but this at least helps improve their quality of life. So, you know, kind of a lot of information, but I wanted to leave enough time for questions. You know, really focusing on the instability of the knee. You know, we've given a lot of arthritis talks, and, you know, people sometimes get bored of those, but here we wanted to focus on the instability and how can we correct that and what's actually involved in doing all those things. It's not just a picture at the knee that you have to think about, it's the whole limb. So with that, we'll open it up to some questions. So the more patella tilt you have, the more, the less centered the patella is going to be. And so that helps give us an information of kind of how loose that medial patellofemoral ligament is. If I can shift it up like that, then it gives it more room to be able to move out. If I can't shift it and it's just staying there, I know that the ligament is tight. But if I can take it and do that, that gives you more opportunity to be able to pop it out. So again, that's basically what this whole talk was about, right? If you have a loose kneecap, we have to look at all those aspects. Is it a ligament problem? Are you someone who's like double jointed and just has loose knees or loose joints? Or is it really actually coming out of the socket? And then we have to look at the hip, get some other studies to assess your alignment and come up with a plan to help that. So, you know, that's, there are many, many types of knee braces to buy. It really depends on your problem. So if it is an instability problem, we like to have what's called a J brace or a patella stabilizing brace, something that has some support on the outer side of the knee to help hold it. Obviously, there's different braces for ACL surgeries and different braces for arthritis. And this is something that some people like it bulky, some people like it less bulky, and they want to be able to play tennis in it. So many different kinds. One, figure out why you need it. And two, is this something that is comfortable for you that you're actually going to wear? Because having the brace sit in the closet doesn't do anybody any good. Running is in itself isn't bad. There's a lot of benefits to running, cardiovascular, bone health. But if you are someone with severe knee arthritis or bad knee arthritis, running for a long period of time can certainly exacerbate that condition. And you have to listen to your body. Maybe you got to only run for 20 minutes and bike for 20 or swim or do something non-impacted. But the running of itself isn't necessarily a bad thing. It just depends on your needs. So, questions about stem cells and arthritis, these are not things that are necessarily fully studied. We know that it's your own tissue, and that's what we like to use. And so it can't hurt you. There is a financial cost to it because it's not covered by insurance. It's still technically considered experimental. It's also not stem cells in the way that you think of, space technology and all these movies where it's going to grow and miraculously produce beautiful cartilage. There are cells that are already down a cartilage and bone pathway, and we're taking those from the bone marrow or the fat in the body, concentrating them and putting them into that site. Now, I prefer to use the fat transfer. Because it has some cells in it, it has nutrients in it, growth factors, and a scaffold to hold those cells and put that into the arthritic joint, whether that's the shoulder, the knee, the hip, or the ankle. So that's my personal preference, but it's certainly something we can talk about in the office, and we can give you some appropriate information about, because you can Google all kinds of stuff. And all kinds of doctors want to charge all kinds of money for that. And sometimes it becomes a cash grab. So they are expensive, but you want to make sure that you're doing it for the right reason and have the appropriate expectations, because that's what people don't sell you is appropriate expectations. So that's a good question, actually, because you hear all kinds of things. A subluxation is when it goes partially out of the joint. A dislocation is when it goes completely out of the joint. That's the same for the shoulder, for the patella, or over the AC joint, you might hear, I separated my shoulder. So that's a similar thing. There's degrees of separation, but it's either subluxed, meaning partially out, or dislocated, meaning fully out. If it's dislocated, you'll see your kneecap sitting on the side of your knee. So you'll physically see a bump on the side of your knee. If it's subluxing or shifting, you may just feel it kind of pop in and out or click, that kind of thing. Now, some people have normal clicking, and that's fine. That's the patella coming into that groove. But a bigger shift will be more painful. You'll see it kind of come out. Well, again, some of that clicking is normal. Some cracking could be early arthritis. The problem with squatting is people go too deep, and that puts a lot of pressure on that patella. So I wouldn't go as deep. I would make sure that your knee is centered over your ankle. Don't let your knee come forward. So a lot of people do this incorrectly. Make sure you talk to a trainer or a therapist to make sure that you're doing it properly. You don't have to squat deep to get a good workout. You can just squat to 45 degrees or 90 degrees, where you're if this is your leg, you just bring your knees kind of parallel or even like that. You don't have to do this motion and really compress that patella. So I think a lot of people have poor squatting technique that gets them into that trouble. Same with lunges.